Welcome to the Deep Dive, the place where we transform dense specialized source material into essential insights and surprising knowledge delivered directly to you.
Our mission today is foundational, yet absolutely critical for anyone serious about public health. We're decoding the precise language of infectious disease control.
Right.
And for this, we're drawing from some really excellent training materials, the kind often used in infection control diploma courses. I'm thinking specifically of the material from Dr. Abdulkareem.
Ah, yeah.
It's just so good at simplifying complex concepts, and it really emphasizes, repeating the main ideas to help with memorization and, more importantly, immediate practical application.
That's right. We aren't just reciting definitions here. We're building the operational vocabulary that dictates how everyone from governments to hospitals to field epidemiologists characterize a crisis.
And how they manage resources, and ultimately how they save lives. These are the fundamental tools used globally, from local health departments all the way up to the CDC.
So it's about the building blocks.
They are the crucial building blocks. Without them, surveillance data is just meaningless noise. They let us move beyond simply observing sickness to, actually calculating risk and predicting transmission.
So let's get into the truth about epidemiology. If we break down the word itself, it's kind of fascinating.
It really is.
Epi means upon, demi means people, and ology means study. So it is literally the study of what befalls a population. And our core mission today really centers on what we're calling the hidden burden. How do these disease detectives define a problem, measure its true scope, and then decide when to intervene? Especially when we know that a huge portion of disease, the part spreading silently, is, hidden from view.
That's the iceberg. We only see the tip.
Exactly. Okay, so let's unpack this. Before we can even begin to identify a crisis, you have to know what normal looks like.
Right. You need a baseline.
In epidemiology, that's everything. And that takes us to our very first definition, endemic.
Endemic describes the constant presence or, and this is the key phrase here, the usual prevalence of a disease within a very defined geographic area or population.
So this is the expected level.
This is the observed level that we accept as the baseline. It's the stable background noise of a disease in a specific location.
So we're talking about malaria in certain regions of Kenya, or maybe the consistent appearance of Lyme disease every summer in places like Long Island, New York.
Exactly. It's present, it's expected, and critically, its existence doesn't trigger an emergency response, even if we all wish it wasn't there.
It's just part of the landscape.
It is. And if that expected level isn't just constant, but it's persistently high, consistently above the average you see in other areas, that level can transition into what we call hyperendemic.
Okay, so that's a step up.
It signals an elevated baseline risk. It requires systemic, long-term policy interventions, even if it's not an acute outbreak.
Then you also have those one-offs, right? The sort of background noise of really low-level disease.
Those are our sporadic cases. These are infrequent, irregular. There's no discernible pattern to them. The cases are isolated, both geographically and in time.
So we think of them as independent events.
Generally, yes, though. We're going to challenge that assumption a little later on.
Okay, interesting. So those are the normal states. They define the status quo. Now let's talk deviation. What happens when that baseline is suddenly and significantly breached?
That's when the hierarchy of deviation comes in, and it moves from the smallest to the largest scope. You have cluster, then outbreak, epidemic, and finally pandemic.
So the very first flag is the cluster.
Right. This is an aggregation of cases. They're grouped in time and place, and we suspect the number is greater than we'd expect.
Even if you don't know the exact baseline number yet.
Exactly. Even if you haven't officially verified it. It's a signal that needs immediate investigation to figure out if it's really excessive or just in coincidence. In terms of size, for planning, a cluster is often level 1.
Moving up in scale, you hit the outbreak.
An outbreak is a localized increase in cases. It's confined to a tight geographic area, maybe a single village, a specific town, or a closed institution like a hospital or a school.
People sometimes confuse it with an epidemic, right?
They do. They're often used interchangeably. But for public health purposes, an outbreak typically describes a more limited area. We classify that as level 2.
And then level 3, the epidemic.
This is a major escalation.
It is. This is an increase, often sudden and really dramatic in the number of cases, significantly above what's normally expected. And it's across a much larger area. Think regional, citywide, maybe even state level?
The key here is the scale of the deviation.
It is. The scale of deviation from that known historical expectation, it demands a much wider jurisdiction-level public health response.
And finally, the largest, and I think the one we're all too familiar with now, is the pandemic.
That's when you have an epidemic that has achieved global spread. It's crossing international borders, it's crossing continents, and it's affecting a massive number of people. That's our level 4. Demanding a coordinated international response, shutting down travel, all of it.
And the strategic importance of distinguishing these categories is, well, it's immense because it legally and politically dictates the level of resources you deploy, the speed of policy, and even the jurisdictional authority, local, state, or federal, that takes the lead.
That makes perfect sense. Now, geography is one thing, but we have to look at how the disease is actually moving.
Yes.
The mechanism of spread tells us if we can stop it by fixing a single point of failure or if we're facing something self-sustaining.
Absolutely. The way an outbreak develops informs the immediate control strategy, and we categorize them primarily based on the source. First, you have common source outbreaks.
Okay.
This is where individuals are all exposed to a shared noxious influence. Overwhelmingly, this means contaminated food or water.
And within that common source dynamic, I imagine the timeline of exposure tells you everything. Take the point source event.
A point source outbreak is characterized by a very brief exposure. It's a single contained event, like everyone eating the same contaminated potato salad at a company picnic.
Right.
Since the exposure is brief, all the cases will emerge roughly within one single incubation period. And the resulting epidemic curve, the epi curve, it'll look like a very sharp, dramatic spike. It suggests the contaminant was removed quickly.
But what if the source remains active? That picture changes dramatically, I'd assume.
It does. That leads to the continuous common source outbreak. Here, the exposure is prolonged.
Like a contaminated city water supply that wasn't shut off right away.
Exactly. Or a food product that stays on supermarket shelves for weeks. Because people are getting sick over an extended period, the epidemic curve's peak flattens and widens out. It's a clear signal that the source of the problem is still active.
Then you have the more complex and often more challenging propagated outbreaks.
Right. These don't rely on a shared external source. They result from person-to-person transmission. It's a continuous chain of infection that spans multiple incubation periods.
This is your classic flu or measles situation.
It is. The curve doesn't just spike and fall. Instead, it accelerates. It leads to that recognizable and frankly terrifying exponential curve, with successively larger peaks as the infection moves through the susceptible population.
And sometimes you get a combination of these, what we call mixed epidemics.
A mixed epidemic might begin as a common source event, say a foodborne illness. That's the initial trigger. But then it's followed by secondary person-to-person spread among the household contacts of those who originally got sick. We see this a lot in institutional settings.
And finally, we have to acknowledge the ecological dimension here, zoonotic or vector-borne outbreaks.
These involve animals or insects. They happen when changes in animal host populations or vector interactions lead to human infection. Think of West Nile, transmitted by mosquitoes, or Lyme disease, carried by ticks.
So you have to understand that entire chain.
You do. The vector's life cycle, the animal reservoir, that's all crucial for prevention because simply treating the human cases won't stop the problem at its source.
Now, this is where we get to a really interesting intellectual pivot in the source material, the analysis that's driven by molecular science. It forces us to question our most basic terms. So let's talk about this molecular rethink. Are endemic diseases just epidemics that we haven't recognized yet?
This is a bit of an existential crisis for the traditional epidemiologist, as you put it, because it challenges the very premise of our surveillance systems.
Not so.
Well, the conventional definitions, endemic, sporadic, epidemic, they rely entirely on what we see clinically and spatially. If we observe a steady, unchanging rate of disease, we call it endemic. A few isolated cases, we call them sporadic.
And the source material argues that this traditional way of differentiating might be misleading or even, quote, not meaningful if we lack granular information.
Exactly. Molecular epidemiology, using things like genotyping or whole genome sequencing, can look beyond the symptom and the location to see the actual genetic signature of the pathogen.
And what does that deeper look reveal?
It reveals that much of what we dismiss as sporadic infections are actually part of unrecognized small outbreaks.
Wow. So the cases look isolated because they're geographically distant or maybe separated by months, but the molecular signature confirms a genetic link. a hidden chain of transmission we completely missed.
It's a profound finding because the default public health assumption is that sporadic cases are anomalies, maybe unrelated, or that an endemic disease is just the unavoidable background risk.
And that perspective can stifle the search for ways to intervene.
It can. The perfect example in the course material is about carbapenem-resistant Klebsiella pneumonia, or CRK pneumonia.
Okay, what happened there?
So when these extremely drug-resistant organisms first emerged in New York hospitals, they were correctly categorized as hospital outbreaks. That prompted intense targeted interventions.
Right.
But as they became established long-term in hospitals along the East Coast, the designation often slipped into endemic CRK pneumonia infections.
That shift from outbreak to endemic, it feels less like a scientific description and more like policy capitulation, like just accepting it as a permanent condition of that hospital environment.
That is precisely the danger. But molecular data, by tracing the specific strains, it sort of precludes the excuse of just calling it endemic. It raises the very strong possibility that these are not just background infections, but that they're actually made up of multiple, small, ongoing, unrecognized epidemics, chains of transmission that could, in theory, be broken if we could just identify the genetic clusters and track their movement.
So the relevance for you, the listener, the infection control professional, is that molecular methods shift the entire goal of surveillance.
Yes, it's no longer passive counting. It's actively seeking out these genetic clusters to unmask the real hidden modes of transmission, even in places where a disease has been, perhaps inaccurately, just dubbed endemic.
It forces us to apply critical thinking to our most basic terms.
It really does. It shows that just characterizing something as endemic or sporadic can hide the underlying dynamics and stop us from finding new, effective control strategies. We have to be willing to question the baseline.
We've thoroughly established the what and the where of infectious diseases. So we get the geography of a crisis, but geography is pretty useless without a clock.
That's a good way to put it.
So let's shift to the biological intervals that dictate our containment strategy, the when and the how much.
Timing is absolutely everything in infection control, especially when you're trying to implement something like contact tracing or quarantine. And we have to clearly separate two fundamental timelines.
Okay.
They are distinct biological events and they're not directly related. They are the incubation period and the latent period.
The incubation period is the one most people get right away.
Yeah.
It's the time from your initial infection to the point of symptom onset.
Right. It's the window where the virus is replicating silently inside you before you feel sick at all. And that's then followed by the symptomatic period.
But the latent period, you're saying, is maybe more critical for public health strategy.
Arguably, yes. This is the time from infection to the acquisition of infectiousness. The moment the host starts shedding enough pathogen to actually transmit it to others, this is followed by the infectious period.
So the distinction is symptom onset versus the biological ability to transmit.
Exactly. And this is where we hit a fundamental weakness in our defensive line, the public health challenge of the mismatch.
The mismatch.
For some of the most challenging diseases, think measles, or more recently, COVID-19, the latent period is often shorter than the incubation period.
Which means significant pre-symptomatic spread occurs. You're capable of transmitting the virus before you even know you're sick.
You're biologically infectious, you're a threat to others before you isolate yourself. And since infectiousness precedes symptoms, containment becomes exponentially harder. You're trying to track infectious people who feel perfectly fine.
That invisible interval, that silent spread. That's why policies like mask mandates became so essential, because they have to assume everyone could be in that dangerous window.
And we have to emphasize the duration of these periods isn't fixed. They're dynamic. They're influenced by several crucial variables.
Okay, so what are the key variables that influence how fast these cycles run?
Well, the first, and often most significant, is the pathogen load, or dose.
The amount you were exposed to initially.
Right. If you're exposed to a very high initial dose of the pathogen, the replication cycle starts faster and it reaches the symptom threshold more quickly. So higher exposure often means a shorter incubation period.
And the mode of transmission must play a massive role, too.
A huge role. Respiratory illnesses generally have rapid turnarounds, shorter incubation periods. Influenza is often 1 to 4 days. Compare that to a blood-borne infection like hepatitis B, which can take weeks or even months to incubate.
And finally, I guess it comes down to the individual, host immunity.
It's highly personalized. Age, underlying immune status, it all influences everything. A compromised host might show symptoms much faster, Or conversely, their body might struggle to clear the virus, which prolongs the infectious period. That variability makes prediction tricky.
Which is why we rely on averages.
Exactly.
So once we get the timeline, we need to quantify the impact. Epidemiologists have to measure not just how many people are infected, but how badly, how easily, and how lethal it is.
Right, and this is where the concept of the burden pyramid comes in. It's a visual way to show that total infections are almost always significantly underestimated. We only ever see the confirmed cases at the very peak,
So starting at the bottom of that pyramid, the broadest measure is population prevalence.
which is just the number of infected people divided by the total people in the population. It gives you that overall snapshot of infection across the whole community, with or without symptoms.
Then moving up, we start defining the consequences. We define the bug's ability to make someone sick with pathogenicity.
Pathogenicity is the ability of the organism to actually cause disease. You calculate it as the number of sick people divided by the total number of infected people. This tells you if the bug is a real clinical problem.
And crucially, we have to measure the asymptomatic proportion, the number of asymptomatic infections divided by the total number infected.
And these silent infections are the critical part of that hidden burden. They fuel transmission without triggering any kind of isolation. It's also important to remember an asymptomatic infection, if it's lab confirmed, is still counted as a confirmed case for surveillance.
Then we quantify severity. This must be strategic for allocating resources.
It is. Virulence is the ability of the pathogen to cause severe disease. It's the number of severely ill people divided by the number of sick people. Low virulence might mean widespread illness, but manageable outpatient treatment.
Whereas high virulence means you need more ICU beds, more ventilators right away.
Immediately. And the ultimate measure of cost and severity is the case fatality ratio, CFR. The number of people who die divided by the total number of sick people.
Yeah, and the source materials remind us that calculating CFR is complex. It's not a single fixed number.
Not at all. For a disease like COVID-19, that ratio can vary dramatically based on the population's age, their health, the quality of the healthcare system. You see it ranging in some studies from 0.7% to 7.2%.
We also use a more specific metric, the attack rate, especially for outbreaks in small, defined groups.
The attack rate, or AR, is calculated as the number in a specific group who get the disease divided by the total number in that group.
Like at a wedding reception.
Perfect example. If 30 out of 100 people at a wedding get sick, the attack rate for that cohort is 30%. This is often the first, fastest metric used in a retrospective study to pinpoint the cause.
So all these metrics assess the impact of the disease. But to assess its sheer spread potential, we turn to the big one, the quantification of transmissibility that became household knowledge. The basic reproductive number, or R0.
$2. It's the pure inherent measure of a pathogen's potential. Defined precisely, it's the average number of people infected by each single case in a completely susceptible population.
So this is before anyone has immunity, before any interventions. It's the worst case scenario.
It is, and the power of this number is terrifying when you look at the exponential scale, which most people, I think, underestimate. If $2 is 22, the size of the outbreak just doubles with each generation.
And that doubling gets out of hand fast.
It does. If you're dealing with a disease where $2 is around 3, like some initial COVID-19 estimates, one case infects 3, those 3 infect 9, 9 infect 27. Within just 8 or 9 generations, that single case has triggered over 6,000 subsequent infections.
Wow, that sequence. $1 right arrow, 3 right arrow, 9 right arrow, 27 right arrow, 243 right arrow, 729 right arrow, 2187 right arrow, 656 of 611. That's what separates a manageable illness from a major crisis.
Absolutely. And then you have something like measles, which has an extremely high $3, sometimes estimated in the teens. That's why you need population immunity up near 95% to stop it.
So the entire goal of public health is to push that number down.
Yes. Once we implement public health and social measures distancing, masks, hand washing, vaccines, we're no longer measuring the theoretical $2. We're measuring the effective reproductive number, or $2.
And the strategic goal is singular.
Yeah.
Push Troy below $1.
Once $1 is less than 1, the epidemic starts to shrink because each case is infecting, on average, less than one other person.
To understand and predict this kind of spread, epidemiologists use conceptual models. The simplest is the Zilla right or R right arrow R draw model.
Right. Susceptible individuals move to infectious and then to recovered. It's a basic framework.
But for modern viruses, especially with that pre-symptomatic spread we talked about, that model seems a bit too simple for accurate forecasting.
It is. That's why we need the more detailed right arrow, E right arrow, I right arrow, R draw model. It introduces the E stage, susceptible to exposed.
And that E stage is that dangerous latent period.
It is. It encapsulates that time when we know the virus is replicating, but it can't be seen or spread yet. Then you move to infectious, and finally to recovered. Adding that E stage allows the models to account for that essential delay.
So the forecasts become more robust, more predictive.
Far more predictive rather than just describing what already happened.
Okay, we've established the geography of the disease and the critical timing metrics. Now we have to discuss how we officially capture that data. When something happens, how do you decide if someone is actually a case that counts?
This is where case definitions become absolutely paramount. Surveillance relies entirely on uniform criteria for reporting. A standard case definition ensures consistency.
So that data from one county is comparable to data from another.
Exactly. So it can be aggregated accurately whether you're looking at a state level or the national NNDSS system. If every jurisdiction defines measles differently, the data is useless.
And the source material reminds us these definitions aren't set in stone. They change as science improves.
Oh, absolutely. Think of the old designation non-A, non-B hepatitis. It was a useful term when we knew something was there but couldn't isolate the agent. It wasn't until the technology improved that it could be precisely defined as hepatitis C.
So a complete case definition has to include what? Clinical criteria? Lab criteria?
Yes, clear clinical criteria, definitive laboratory criteria, and often epidemiological criteria, like having contact with another known case.
Let's break down the classification hierarchy. Suspected, probable, and confirmed. Starting at the top, what makes a case confirmed?
A confirmed case is the gold standard. It always requires definitive laboratory confirmation. For instance, to confirm plague, you need to isolate Yersinia pestis from a clinical specimen.
It's not enough just to look sick.
No. For typhoid fever, the standards are incredibly strict. You must isolate S. typhi. Serologic evidence alone is not enough. And we should note, an asymptomatic infection, if it's lab confirmed, say a positive PCR test in a healthy person, is still counted as a confirmed case.
Because they can still transmit it. Okay, moving down to the middle tier, we have a probable case.
A probable case represents a high degree of clinical certainty without that absolute lab confirmation. This usually means a clinically compatible illness plus some supportive lab results. Or, and this is critical, it can be defined by an epidemiological link to a confirmed case in a known outbreak.
So they look the part, and we know they were exposed.
That's it. We treat them as probable. And then the widest net is the suspected case.
Okay.
A suspected case captures individuals who meet the clinical criteria but lack definitive lab evidence or epilinks. This is essential in the early days of an outbreak when lab capacity might be overwhelmed.
Like someone with a characteristic rash for Mpox, or maybe a positive at-home antigen test.
Perfect examples. Both probable and confirmed cases are reported to the National Notifiable Diseases Surveillance System, the NNDSS, but only confirmed cases, the ones with that definitive lab diagnosis, are reported to the more specific laboratory-based surveillance systems.
Now we shift from classifying cases to mobilizing action, the outbreak investigation. The source material outlines a systematic approach, often called the 13-step plan.
This is the field manual for disease detectives. It's often described as needing to be quick and clean. You have to move fast, but with scientific rigor. And while the steps are presented in order, in reality, a lot of them happen at the same time.
Control measures often begin early, I'd imagine.
Oh yeah, often before the hypothesis is even fully confirmed.
So let's focus on the crucial early steps. Step 3 is verify the diagnosis. Why is this prioritized even before finding all the cases?
Because if you're chasing the wrong diagnosis, everything else is useless. Verification means reviewing clinical findings, lab results, and making sure the lab techniques themselves are sound. You have to secure specialized specimens for things like DNA fingerprinting before the pathogen degrades.
So once we know the enemy, we need to know the scope. Step 5 is find cases systematically.
Right, because the initial reports are never the full picture. That's the hidden burden. To find the true scope, you might use enhanced passive surveillance, actively asking healthcare facilities to report similar cases.
And the more resource-intensive route is active surveillance.
That's right. That means investigators are proactively telephoning or physically visiting clinics and labs to collect information. It's critical in areas where passive reporting might be weak.
Once you've captured the data, you organize it. Step 6, perform descriptive epidemiology. summarized by time, place, and person.
This gives you a full characterization. By looking at who is sick, where they are, and when they got sick, you start identifying the population at risk and generating hypotheses about the source and mode of transmission.
Which leads right to step 8, evaluate hypotheses. How do you do that scientifically in the field when time is short?
It's a synthesis of all the evidence. You compare your hypothesis against established facts, lab science, and most powerfully, analytic epidemiology. For a small, well-defined group, like wedding guests, the go-to is often the retrospective cohort study.
You track everyone, find out their exposures, and see who got sick.
And calculate those specific attack rates. And then step 11 is the action phase. Implement control and prevention measures. But like we said, this often starts as soon as the source is strongly suspected. You don't wait for final confirmation to recall a contaminated food product.
One of the most basic, yet most powerful tools in all of this is the visual representation. The epidemic curve or epicurve.
The epicurve is a core skill. It visually shows the magnitude of the epidemic over time. It immediately separates an acute ongoing problem from the steady background noise of endemic disease.
And its shape reveals the mechanism of spread we discussed earlier.
Absolutely. A sharp peak and rapid fall tells you it was a point source that's now controlled. An elongated flat peak suggests a continuous source, and those accelerating rising peaks clearly show a sustained propagated outbreak.
You can also work backwards from it.
You can. If you know the incubation period, you can deduce the probable time of exposure for the group, which helps you design your questionnaires.
And the advice from the source material about the epicurve is to focus intensely on the unexpected, the outliers.
That is critical thinking in action. Most investigators are tempted to dismiss the cases that don't fit the main curve, but those outliers often hold the biggest clues.
Let's slow down and tell that story of the thyrotoxicosis outbreak in 1985. It's a perfect example.
Yeah, so the outbreak of thyrotoxicosis was primarily centered in Luverne, Minnesota. The investigation was focused there, but one single outlier case appeared 60 miles away in Sioux Falls, South Dakota.
A busy investigator might just dismiss that. Why travel 60 miles for one case?
But these investigators didn't. They followed the outlier. They asked the Sioux Falls patient a simple series of questions. Did you ever go to Luverne? Yes. Were you friends with the other cases? Not really. What do you do there?
And the answer was the breakthrough.
The answer was, I visit my father, and I always buy the locally produced ground beef that he sells in his store. That single outlier case provided the hypothesis that ground beef contaminated with Roundup thyroid glands was the vehicle, which they could then immediately test against the whole Luverne cohort. And it proved to be correct. All because they didn't dismiss the anomaly.
After all the investigation, the diagnosis, the hypothesis testing, we arrive at the central point, intervention.
Right. And the control measures have to be strategically directed against one or more segments of that fragile chain of transmission.
We can categorize these interventions based on the target, right? The agent, the mode of transmission, the portal of entry, or the host.
Exactly. Let's start with targeting the agent or source. This involves either treating the infected person like giving antibiotics for TB to render them non-infectious, or if the source is environmental, like in the soil, the intervention is decontamination.
Next, blocking the mode of transmission. This is where most day-to-day infection control lives.
This is the biggest category. For direct transmission, you use isolation or counseling. In a nursing home, you use cohorting grouping affected residents together with dedicated staff to prevent spread.
And for indirect modes.
That means eliminating vehicles. You discard contaminated food, sterilize surgical equipment. For airborne diseases, you modify ventilation, ensure negative pressure rooms, use HEPA filtration.
What about protecting the portal of entry?
This is all about physical barriers, PPE, a dentist's mask and gloves, a healthcare worker's gown. In an ecological sense, it's bed nets against mosquitoes or repellents for ticks.
And finally, strengthening the host defenses.
This is the long-term strategy. Primarily, it's vaccination, which promotes antibodies. It also includes prophylaxis, like anti-malarial drugs for travelers. The drug doesn't stop the bite, but it stops the infection from taking hold.
Once control measures are implemented, the process isn't over. Step 12 is to initiate or maintain active surveillance to audit the effectiveness of those interventions.
This is the accountability phase. It's crucial for infection control professionals. Are new cases slowing down? You have to keep monitoring. And this phase demands really practical data management skills.
This brings us directly to the practical application skills emphasized in Dr. Abdulkareem's material. especially for assuring audits and follow-up.
Yes.
Surveillance often involves these highly detailed procedural checklists, like the one provided for auditing hand hygiene with soap and water.
The detail there is fascinating. It breaks down what seems like a simple act into 8 measurable steps that define success or failure in a clinical setting.
Walk us through those 8 steps. They really reveal the level of rigor required.
It starts with logistics. 1, check that the sink area is supplied with soap and paper towels, fails immediately if not. 2, turn on the faucet. 3, wet hands and apply enough soap. 4, vigorously rub hands for at least 20 seconds, covering all surfaces. 5, rinse thoroughly with fingertips pointed down. 6, dry hands and wrists with paper towels. 7, discard the paper towel.
And the final step, which is where a lot of people probably fail when they're rushing.
Use the paper towel to turn off the faucet to prevent recontamination. The faucet, turned on with soiled hands, is now a contaminated surface. Touching it again with clean hands reintroduces risk.
That level of rigor translates directly into data management. The course material stresses proficiency in tools like Microsoft Excel.
Exactly. These aren't just bookkeeping skills, they're essential for surveillance. Simple things, like using freeze panes to keep headers visible when you're scrolling through hundreds of audit records, or using the fill handle for efficient data entry. They're fundamental to the quality of the whole process.
Now we're going to shift gears completely, moving from the clinical audit to the chaos of the global environment. Natural disasters fundamentally change the whole epidemiological landscape.
They do. Natural disasters, particularly floods, which are the most widespread and destructive calamities, significantly increase infectious disease risk. They contaminate everything, they cause massive population displacement, and they destroy sanitation and healthcare systems.
And this breakdown consistently leads to outbreaks, right? Diarrheal diseases, cholera, respiratory infections.
But the problem for epidemiologists is that in the chaos of a disaster, good baseline surveillance data is often non-existent. It makes it incredibly hard to interpret the sudden surge in cases.
This is exactly why the field is moving from reactive investigation to predictive science, using modern technology.
Right. The source material highlights the validation of sophisticated machine learning models like random forest, gradient boosting, and artificial neural networks to forecast post-disaster disease incidents.
These sound incredibly complex. How do they work?
Essentially, they're models that can spot complex, nonlinear patterns in huge data sets that a human would miss. Random forest and gradient boosting are ensemble methods. They combine many different decision trees to reach a consensus, making them robust against noisy real-world data.
So what were the key findings from the study that analyzed post-flood disease prevalence using health records?
It was a retrospective study comparing a 30-day period before a major flood with a 30-day period right after. And they found that infectious disease prevalence increased significantly from about 39.5% pre-flood to 47.3% post-flood.
A clear and measurable risk, an odds ratio of 1.38.
Yes. The flood caused a measurable health burden, and the AI models showed moderate predictive performance. Random forest was the best, with an area under the curve, or AUC, of 0.76.
Which is moderate, but it shows it's feasible to use AI in disaster epi.
It does. And what really stands out is what the models identified as the most important predictive features.
What were they?
Across all models, the most important features were age and visit date. And critically, the findings revealed a counterintuitive insight. Younger patients showed significantly higher post-flood infection rates compared to older patients.
That's a highly actionable intelligence.
It is. If predictive systems can flag younger patients as the highest risk demographic right after a disaster, health resources can be preemptively allocated to areas with younger families. It moves the response from reactive to proactive.
But the study also gave a reality check.
It did. The modest performance signaled that for these systems to be truly clinically actionable, they need to incorporate more data environmental socioeconomic variables. AI is only as good as the data we feed it.
This need for comprehensive data brings us to the future of integrated assessment, the One Health paradigm.
The dynamics of modern infectious diseases, especially the emerging zoonotic threats that jump from animals to humans, are just too complex to be understood through a human-only lens.
So, One Health is what?
It's an approach that requires integrated assessment. It recognizes the inseparable connections between human health, animal health, and environmental health.
It acknowledges that the pathogen cycle doesn't stop at the hospital door.
Precisely. It's the necessary paradigm for controlling complex modern diseases. It ensures we're not just vaccinating humans, but tracking wildlife, monitoring livestock health, and assessing environmental changes that might push vectors into human habitats. It synthesizes everything we've talked about today.
So we've really taken a journey today. We've moved from the basic required vocabulary of endemic disease all the way to the complex math of our dollars, and finally to the cutting edge of AI prediction systems.
And I think the foundational lesson, which is driven home so well by the quality of Dr. Abdulkareem's material, is that effective public health response hinges entirely on the precision of our terminology and the rigor of our measurement.
Okay, let's unpack this. The effectiveness of our response. I mean, whether we're talking about a global pandemic or just ensuring the 8 steps of hand hygiene in a local hospital, it all hinges on the clarity of these foundational definitions.
And the speed and scientific accuracy of our data collection.
Right. If you confuse incubation with latency, you completely miss the pre-symptomatic spread. If you confuse an outbreak with endemic disease, you might miss a chance to intervene.
And this data, whether it's the attack rate in a school or the confirmed case count reported to the NNDSS, it helps us translate what we see into measurable intervention. We need that clear, consistent classification hierarchy: suspected, probable, confirmed, to make sound decisions under extreme pressure.
So the key takeaway for you, the professional learner, is that critical thinking is essential. Surveillance systems, fundamentally, they show us the tip of the iceberg, right? That visible burden. But what we discussed in part 1 is the crucial modern development. Molecular and AI tools are forcing us to look deeper. We have to recognize that many infections we used to just accept as sporadic or endemic are actually solvable hidden chains. They unmask transmission modes we never knew about before.
The traditional categories, endemic versus epidemic, are proving to be conceptual flags, not these rigid biological boxes. When molecular techniques reveal genetic clusters and what look like unrelated cases, those connections give you an immediate actionable opportunity for intervention that was just missed by simple case counting.
And that leaves us with this final provocative thought for you to mull over. Given that molecular epidemiology shows that endemic often equals unrecognized small outbreaks, what previously accepted baseline in your field, whether it's a hospital-acquired infection rate, a community disease cluster, or even the expected flu rate, is actually ripe for a major public health intervention, if only the cases were genetically linked. The true challenge in epidemiology isn't just counting the sick, it's revealing the hidden connections that bind them.